Now, with both of these conditions, it leads to decreased filling of the heart. Now, let me break that up for you. Remember, the pericardial cavity is being filled pathologically. But in the meantime, what is it doing to the heart? It's restricting it. So therefore, now you tell me, what kind of dysfunction is this? Good. A diastolic dysfunction, because you can't fill up the heart. Do you understand that? So you bring in your physiology, you understand the pathology, and ultimately, you'll figure out who your patient is. Now, if the filling is so restricted within the heart, ultimately, you're going to result in shock. Now, what is the definition of shock? You've been exposed to numerous types of shocks. Dr. Raj's shock? No, I'm joking. You've been exposed to numerous number of shocks. These include cardiogenic shock. Wow, what happened? Heart stopped. The heart has decreased cardiac output. Maybe it's septic shock, also called neurogenic shock. What happened there? Wow, there was a gram-negative organism, lipopolysaccharide. Maybe it's an E. coli organism from a catheterization, which all of a sudden resulted in a septic shock. And then you have hypovolemic shock, right? So what's the common denominator? Apart from the term shock, what does it actually mean? Well, whatever the case may be, let it be decreased cardiac output, in this case, due to decreased filling, the tissue is not receiving enough oxygen. If it's septic shock in microbiology, you know that there, because of the organism, the tissue is not receiving enough oxygen for different reasons that we're not going to go through here. And then hypovolemic shock. Well, there, what happened? Got into an accident, perhaps there was a laceration. Maybe your patient was working with a heavy machine and got trapped, and then all of a sudden was losing tons of blood. Hypovolemic shock. What's the state of my tissue? It's starving for oxygen. Are you seeing this? So everything that you do in medicine, give it a clinical tag, and you can never go wrong. If you cannot give it a clinical tag initially, I would just let it go. And at some point in time, when you've gotten a firm hold of clinical medicine, then you can go into the itty-bitty details. Now, cardiac tamponade may be caused by a small amount of fluid. That is huge for you to understand. Because up until this point, I've been saying accumulation of fluid. But what exactly does that mean? Accumulation of fluid in a rapid motion or in a rapid manner would then be cardiac tamponade. It doesn't have to be a lot of fluid, but a little bit of fluid accumulating within your pericardial cavity. Oh my goodness, tamponade. You might be at risk for death. What about slowly? Well, if it's slow effusion, then that's not necessarily called tamponade. It just means pericardial effusion, and I'll show you the comparison between the two in a little bit. Large amounts may accumulate gradually is the operative term. Do you see that? Gradually, without causing tamponade. Are you seeing the differences? I've been harping on this a few times. I'm hoping that it's getting reinforced in your head, if not already. If you're thinking about gradual accumulation of fluid, malignancy, or we'll take a look at other etiologies, but I'd like for you to think of malignancy, and oftentimes, well, what kind of fluid is accumulating in your pericardial cavity or cavities in general? Okay, so here's a graph in which we're comparing acute versus chronic type of accumulation of fluid within the pericardial cavity. The first one on your left is rapid effusion. So this would be acute, rapid accumulation of how much fluid? Take a look at the x-axis. Remember, I have told you, and you have gotten into the habit of dissecting your graph into x-axis and a y-axis. The x-axis is horizontal here, and you'll notice that this is volume. The y-axis will be the pressure. Now, your focus here initially for acute is going to be, well, how quickly did volume accumulate? In acute, very quickly. Whoa. Now I have reached the limit of pericardial stretch very quickly with how much volume? Not much, but very quickly, And you end up getting into what's known as critical tamponade, in which the patient now is at risk for what kind of dysfunction? Can't fill it up. So therefore there might be shock, decreased cardiac output. Now, granted, there's different ways that you can have decreased cardiac output, This is one of them. What if there was an MI? Well, that's a different reason for cardiogenic shock. If it's myocardial infarction, it's just the fact there was lack of oxygen. There's ischemia to the heart. Dead is the heart. Obviously may result in cardiogenic shock. Let's take a look at this and compare it to our chronic. And chronic, well, here, the critical tamponade region or area would be one in which it takes more time for the fluid to accumulate in the pericardial cavity. Give yourself an example, such as malignancy. Give yourself an example for cardiac tamponade, such as a ventricular wall rupture. Ventricular wall rupture. A few times now, we've also talked about rupture. You want to keep in mind or keep separate wall rupture versus septal rupture, right? Septal rupture would result in a VSD type, a systolic murmur. A wall rupture would then result in rapid accumulation of fluid, cardiac tamponade. Now here, you'll notice the critical tamponade region for slow effusion takes a little bit more time. These are important comparisons so that you clearly distinguish between acute and chronic type of effusions.